Endometriosis is in simple word, lining of the womb lying outside mainly the pelvis, but it can affect many parts of the body. If the lining of the womb within the muscles of the womb, it's called adenomyosis, which is usually happen slightly around 30, 40, but it can happen in young patients. But endometriosis is lining of the womb outside the womb, most of the time in pelvis, affecting many young women and causing pain during period, pain during sexual intercourse, chronic pain, affecting fertility, and creating a large amount of socio-economic burden for the families. So endometriosis is in golden standard diagnosis is laparoscopy. We first focus on the patient symptoms. The main symptom is start with young girls around 20, 22, or sometime early, painful period, pain start before period. Having said, painful period is quite common at 15, 16, 17. Not every patient develop endometriosis on those patients, but some patients, the pain get worse during the period and before the period. That may be the early signs. But it doesn't mean all the patients need to have laparoscopy to diagnose endometriosis. That is unfair for the woman, and it's not economically for a country valuable to do laparoscopy for every patient. The best way is focusing on the patient who has significant pain before period and throughout the period, significant pain affecting day-to-day life, especially pelvic pain, pain during sexual intercourse, and patients who are unable to conceive. On those patients, people who scan, especially for endometriosis, is the best way to diagnose. We, for example, people like me, when we scan, we just not focus on uterus and ovaries. We look at the bladder surface, we look at the uterus, we look at the muscles part of the womb. Then we look at the ovaries, mobility of ovaries. Then specifically for endometriosis patient, if the patient tolerate, we look at the uterosacral ligament, which is the ligament that connect to the neck of the womb to the back part to stabilize the womb. These are the places usually the endometriosis mainly start and cause significant pain. We look at the uterosacral ligament and then guess whether this patient have endometriosis or severe endometriosis. Then only we go for laparoscopy only on the patient who will benefit on it. We should not be starting laparoscopy for every patient who has pain. We should be first start on symptom assessment and then ultrasound scan, especially transvaginal scan with the transvaginal 3D scan, specifically look for endometriosis and then go for laparoscopy. A routine transvaginal scan done by a person who not focus on endometriosis may not exclude endometriosis. So transvaginal scan doesn't exclude endometriosis, but it's quite easy to diagnose severe endometriosis by transvaginal scan. And then we go for laparoscopy, which is under general anesthesia, a keyhole surgery with usually 3 keyhole, diagnose endometriosis. Advantage of laparoscopy is at the same time we can excise and remove the endometriosis if it is needed. It affects women in many ways. For example, it's affect with severe pain affecting before period, throughout the period. Patients are worrying about the period and stay away from the work, school, university during the period and end up in taking a lot of painkillers. So it's affect their socio-economic and psychological well-being. It other ways affect is avoiding sex because of the severe pain during sex experience. Some of the patient may need not just surgery and treatment, may need counseling to get on with their life. They affect fertility. Not every woman with endometriosis have difficulty in conceiving, but it's actually one of the main problem in patients with subfertility who have mild to moderate endometriosis, who was not diagnosed. But it doesn't mean diagnosing increased the fertility on patients who are unexplained, but it actually helped them to go for the treatment choices such as IVF. The other way is chronic long-term endometriosis affecting the fallopian tube mobility, fallopian tube function in catching the egg and fertilizing and transferring the embryo into the uterus. So they cause subfertility. Sometimes endometriosis affecting a large ovary called endometrioma may need surgery before any kind of treatment with fertility such as IVF. Endometriosis can actually affect the bowel, which is called stage 3, stage 4 endometriosis, and cause significant problems. The surgery is slightly challenging and done only in BSG endometriotic centers. It can affect the ureter, which connecting the kidney to the bladder. It can create quite a significant back pain. A patient with endometriosis and back pain may need MRI scan to understand severity before going for surgery. Endometriosis affected women's family life, their sports quality of life, and the psychological well-being. It's not uncommon endometriosis associated with irritable bowel syndrome and patient with anxiety, unable to function day-to-day life, especially during period and just before period. First, how does it affect fertility? It affects fertility in many ways. The main thing is it creates inflammation, not infection, inflammation into the pelvis and create decreased mobility of the function of fallopian tube. So those patients, sometimes the fallopian tube is patent during the investigation. It doesn't mean it's functionally normal. In chronic endometriosis, it causes adhesions and sometimes severe affection of the fallopian tube cause blocked fallopian tubes and hydrosalpinx or hematosalpinx where the tube is dilated with fluid or blood, meaning removal before IVF or in vitro fertilization. Sometime in some women, endometriosis create a big ovarian cyst called endometrioma. If the endometrioma is small, around 3-4 centimeter, doesn't need surgery before IVF because surgery can decrease the ovarian, the amount of egg that they can collect, or in other ways called follicular count. But if the endometrioma is quite big, like 6 to 7 centimeter, it's better to do a surgery before IVF egg collection to decrease the complication at the time of egg collection and good quality of embryo. Endometriosis, there are some studies shows endometriosis associated with miscarriage, but it's not large amount of proven value in view of endometriosis and miscarriage. But adenomyosis, which is like another one part of endometriosis, which endometriosis women have adenomyosis, quite significantly associated with miscarriage. Next, if you go for hormonal treatment, the problem is patient with fertility doesn't want a hormonal treatment because they are trying to conceive, and all the whole hormonal treatment are indirectly contraception. But the patient who doesn't plan for fertility urgently, the hormonal treatment is ideal choice. We'll go to the next question as the hormonal medication without surgery. So hormonal medication is an ideal choice for minimal endometriosis, early endometriosis, young patient. So we do not need to do diagnostic laparoscopy after the ultrasound scan. Either patient have a laparoscopy, an excision of the endometriosis, or patient who had a diagnostic laparoscopy, or with symptom and scan suggesting of endometriosis may benefit from hormonal treatment. The ideal choice is there are different types of progesterone-only pill. The progesterone-only pill control the endometriosis and decrease the recurrence of endometriosis after the surgery. It can be desoestrol, Dynogest, or Mirena coil. Marina coil is effective after surgery, but evidence shows progesterone-only pill is better than Marina coil on some studies. Combined oral contraceptive pills, which is we use very commonly and is very good for young patients, control the endometriosis, decrease the pain, but it doesn't prevent recurrence compared to progesterone-only pill in some studies observed. So if I see a patient who are less than 23, I might try with a combined oral contraceptive pill in first instance before progesterone-only pill, because combined oral contraceptive pill side effects such as bloating, intermenstrual bleeding is less compared to progesterone-only pill. But if I diagnose severe endometriosis or excision of endometriosis, I usually go for progesterone-only pill or Mirena coil. There are other medications coming on, such as the oral GnRH and different medication, but usually we apply progesterone-only pill, Mirena coil, combined oral contraceptive pill. We have GnRH analog and antagonist, oral or injection, which is for severe endometriosis. Mainly we use them after the surgery to avoid recurrence and relapses. Deep endometriosis, we usually, if the patient is significant pain, problem with bowel emptying, or affecting the ureter, we do the surgery, as we are one of the deep endometriotic surgical BSG professional or accredited center. In UK, deep endometriosis is mainly operated in BSG, British Society of Gynecology Endoscopy accredited center. So we monitor the patient effect and the surgery nationally, and we follow up for 2 years. Now, the surgery is ideally sometime 2-stage, sometime 1-stage, and resect the endometriosis. If the woman haven't completed the family and young, planning to have children, when we remove the peritoneum, endometriosis, dissect the bowel, remove the retrovaginal nodule. If the woman has completed the family, we completely remove the hysterectomy, remove the endometriosis, plus or minus ovaries. These surgeries are much more high risk of complication and take around 2 to 3 hours of operation. Sometimes need 2 surgeons or 3 surgeons. So these surgeries are much complicated. But after the surgery, we may employ, if we have to remove the ovaries, a GnRH analog injection. These surgeries have risk of bowel, bladder, ureter damage. So we need to have the surgery done endometriotic center, and to avoid complications, sometimes we counsel the patient appropriately. We also, in my centers, patient may will get pain management, consultant appointment before surgery, bowel preparation sometimes, and also patient will be offered counseling before surgery. We have to note, not every patient get pain 100% free after the surgery. So the psychological counseling improve the patient quality of life after the surgery much, much better.